Welcome back, everyone. Let's get into the topic acute rheumatic fever. Let's see what happens in acute rheumatic fever. It is an acute immune mediated inflammatory disease that occurs after the infection by group A streptococcus and typically pharyngitis. And here's the main tissues which is affected in rheumatic fever. And then the etiology. Here, the causative organism is group A beta hemolytic streptococcus, and these are the main M serotypes, and it occurs mostly after streptococcal sore throat and not after skin infections like impetigo. And there will be a latent period of around 3 weeks between the infection and occurrence of rheumatic fever. And here's the pathogenesis. The main mechanism here is molecular mimicry and how it works. Here, the antibodies formed against M protein. The M protein resembles many human tissues like cardiomyosin and valve endothelium. So, the antibodies formed against M protein attacks valve endothelium and cardiomyosin and other tissues. And there's an alternative hypothesis. Here, the initial damage is by invasion of streptococcus bacteria into the epithelial surfaces. And here, when invading, it binds the M protein into collagen 4, which makes collagen 4 immunogenic and leads to immune mediated reactions. And the next thing is cardiac lesions. Here, the cardiac lesions affects all three layers of heart, that is endocardium, myocardium and pericardium. And endothelium, the main thing happens is valvulitis, and commonly affected valve is mitral valve. And myocardium, here the characteristic feature is Ashkow bodies. Here you can see it is a foci of granulomatous inflammation. It is surrounded by various cells called Anisco cells or caterpillar cells, and it's a form of macrophages. And then pericardium. Here there will be fibrinous pericarditis, which appears like bread and butter. And then extracardiac lesions. Here, joint involvement, subcutaneous nodules, and pleural lesions like fibrinous pleuricy, and pulmonary lesions like rheumatic pneumonitis, and some of the non-specific findings in the brain of patients with chorea. Here, the main thing and important exam-wise topic is Jones criteria. Here, it's named after the T. Duckett Jones, and these are the supportive evidence like scarlet fever, positive throat culture, and increased antibodies. Here you can see the diagnostic criteria, that is initial acute rheumatic fever and recurrent acute rheumatic fever. At first, initial, it will be two major criteria or one major plus two minor criteria. And recurrent, here two major criteria or one major plus two minor criteria or three minor criteria. And in major criteria and minor criteria, we divide the population into low risk and high risk population. Here, the incidence of acute rheumatic fever will be less than 2 per 1 lakh school age children, and prevalence of rheumatic heart disease is less than 1 per 100 population per year, and this is for low risk population, and the rest is high risk population. And let's see Jones minor criteria. Here you can easily learn this by the mnemonic Jones. Jones, J for joints, that is migratory polyarthritis, and O you can make O as heart, that is carditis, and it's most serious thing. And then N for nodules, E for erythema marginatum, and S for Sydenham's chorea. Here you can see in low risk population only arthritis, polyarthritis is present, and in high risk population arthritis, mono and poly, and even arthralgia is also present. Here arthritis is inflammation of joint and arthralgia is pain in the joint. And then minor criteria. Here the low risk and high risk population is present. Here you can see arthralgia in multiple joints and in even single joint pain, and fever. Fever with temperature more than 38.5, and in high risk it's just 38. And ESR it's 60 and 30. CRP same, and ECG changes also same. And then migratory polyarthritis. What is migratory? That is, it changes its position from one joint to another joint over a period, and it is the most common features of acute rheumatic fever, and it affects mostly large joints like knee, ankles, and elbows. And the main thing is it responds dramatically to aspirin, and you can easily take it as a clue. If it responds to aspirin dramatically, it might be because of migratory polyarthritis in acute rheumatic fever. And then carditis. Here 75% of acute rheumatic fever leads to rheumatic heart disease, and the most common valve involved is mitral valve, and aortic valve may or may not be involved. And then the common thing happen is regurgitation at earlier regurgitation, and later due to fibrosis and calcification stenosis may occur. And the main signs are PR prolongation and soft S1 heart sound, first heart sound, and it might be asymptomatic for years. And the diagnosis is mainly by echo, and the definite rheumatic heart disease if present, the prophylaxis should be taken definitely. And then Sydenham's chorea, also called Sen Vitus dance. It is a form of involuntary movement as the basal ganglia is affected, and it has a long latent periods, that is the time period between infection and the occurrence of chorea, and it is common in females. And chorea, it occurs mainly in head and upper limbs, and tongue darting is a common feature. And then psychiatric thing like emotional lability and obsessive compulsive disorder will be present, and it resolves from weeks to months. And the main thing is more than 50% of patients with chorea there will be carditis. So if chorea is present, it's mandatory to do echocardiography. And these are the some importance exam viva questions like milkmaid grips, irregular squeezing of fingers, and darting tongue signs, inability to keep tongue protruded, and pronator signs, arm pronate when extended, and jack in the box tongue pops in and out. And then skin manifestations. And here the skin manifestations are erythema marginatum. That is, there will be pink macules with central clearing. Here you can see the center is clear with serpiginous edges, and the main feature is it's evanescent. It comes and goes on its own, and it's common in trunk and limbs and not in face. And the other skin manifestation is subcutaneous nodules. It is painless mobile nodules seen over brawny prominences, and it occurs after 2 to 3 weeks and has a short duration, and it is mostly associated with carditis. And then the investigation. Here the main investigation are ESR, CRP and ASO titer, and anti-DNA is B. These are all will be elevated in this. And then ECG. Here there will be prolonged PR interval, and the main investigation is echocardiography. It detects the valvular movement, and even subclinical carditis can be easily detected using echocardiography, and it's also included in Jones criteria, clinical or echo. And the main feature in echo is hockey stick or an elbow deformity. And let's see the treatment of rheumatic fever. The treatment mainly starts with eradication of streptococcus, and the drug of choice is benzathine penicillin G, and its dose mainly depend on weight. People with less than 27 kgs, we give single 6 lakh unit IM dose, and then more than 27 kgs, 12 lakh international units IM single dose. And there are alternatives like oral penicillin V for 10 days or amoxicillin for 10 days. And in case of penicillin allergies, macrolides, example azithromycins are used. And then anti-inflammatory therapy. Here the most common problem is arthritis and carditis. Aspirin is enough for arthritis, and it's the diagnostic clue. As I already referred, dramatic response to aspirin, then it's because of acute rheumatic fever. And we should continue aspirin until inflammatory markers and symptoms resolve. And carditis. In carditis, for mild carditis, aspirin alone is enough. And for moderate to severe carditis, we have to give corticosteroids with a dose of 1 to 2 milligram per kg per day. And after stopping steroids, we have to give aspirin to prevent rebound inflammation. And then management of Sydenham's chorea. Here it is usually self-limiting, but if severe, we have to give sodium valproate, and other drugs like carbamazepines and haloperidol may also be given. And we have to avoid stress as it may worsen chorea. And management of heart failure. Here the management will be with diuretics, AC inhibitors, and digoxin may or may not be given. And you can learn the standard heart failure management in separate video in our channel. And supportive care, it's bed rest, monitor ESR-CRP, and regular cardiac evaluation. And then primary prophylaxis. Here, the primary prophylaxis means prevent first attack, that is before disease. So we have to treat the risk factor, that is infection by streptococcus, and the drug of choice is penicillin. And then secondary prophylaxis. Here the prophylaxis is before complication but after rheumatic fever. So the drug of choice is penicillin G, benzathine penicillin G, and the dose is given here. And alternatives are oral penicillin V, and in case of penicillin allergy, macrolides like erythromycin is used. And here the duration of prophylaxis is decided by category of patients. Here, rheumatic fever without carditis, that prophylaxis for 5 years after the last attack or up to 21 years of age. And rheumatic fever with carditis but no residual valvular disease for 10 years after the last attack or up to 21 years of age. And then rheumatic fever with persistent valvular disease evident clinically or echocardiographically, and it is for 10 years after the last attack or up to 40 years of age. And in all these, whichever period is longer is taken as duration of therapy. And do like, share and subscribe for more such contents. Thank you.